guys, good morning. So today we are going to discuss our next topic, that is the management of various malocclusion. So first we are going to discuss about the management of class 2 malocclusion. So in this, these are some of the features. So a class 2 patient having a class 2 molar relationship, this is the distobuccal cusp of the upper maxillary permanent molar falls into the buccal groove of the mandibular first permanent molar. This is class 2. So in these type of patients you will find class 2 molar relationship on both the sides. There is an increase over jet. Why? Due to the proclination of the maxillary incisors. So the patient exhibits a convex facial profile. The lips are incompetent. Why the lips are incompetent? Due to the proclination of the upper incisors. So in this, the patient is unable to close the lip, or there is a low lip seal formed. Next feature is the lip trap, very important for your MCQ. So what is lip trap? Due to the proclination of the upper incisors, these are the upper incisors, due to the hypotonic upper lip in which there is no lip seal is formed, the lips are incompetent. In this, the patient is unable to close the lip. Right? So in this way, this is the proclination of the upper incisor. So in this, the patient, it may place the lower lip. Suppose this is the lower lip. So he or she, they place the lower lip against the palatal surface of the upper incisor. So this is what we called as lip trap. So in class 2 patients, the patients have an constricted or narrow maxillary arch. There is V-shaped upper arch, right? And in this, skeletally, the class 2 malocclusion, it may be due to the maxillary protrusion or the maxillary prognathism, due to mandibular retrognathism, or the combination of these two. Fine. See, in this, if a patient comes to you, if an ortho patient comes to you with the retruded mandible, if he comes to you at the age or in his growing age, then you will correct his retrognathism of the mandible by giving the myofunctional appliances. If he comes to you at the age of 16 to 17 years, then you will go for the fixed orthodontic treatment. You have to place the brackets and arch wire. But if he comes to you with a severe retrognathism of a mandible after 20 years of age, then you go for the surgery. So these are the three treatment modalities: in a growing patient, in a non-growing patient, and in a patient who require the surgery. Right? So after this, coming on to the management part. See, in this class 2 malocclusion, you treat a malocclusion in a growing individual and in a non-growing individual. Let's discuss first about the growing individual. So the growing individual, the class 2 malocclusion, it may be due to the skeletal or it may be due to the dental. So if the malocclusion, it is due to the skeletal or skeletal factor, then there may be, if the patient having a prognathic maxilla, in that case you will give the headgear. Why headgear? To restrict the growth of the maxilla. Restrict the growth of the maxilla. Fine. Second is, if a patient of class 2 comes to you with the retruded mandible, in that case you will give myofunctional appliances. Fine. If a patient comes to you having a prognathic maxilla and retruded mandible, that is the combination, in that case you will give the headgear for the prognathic maxilla and you will give the myofunction for the retrognathic mandible. Right? And myofunction appliances, you can give the twin block, you can give the FR, any kind of myofunction appliance depending upon the case selection. And if a class 2 malocclusion is due to dental, then you go for the orthodontic treatment. So this is all about a growing individual. When a patient comes to you in his non-growing age, so dentally you will perform the orthodontic treatment, and skeletally, if there is mild to moderate class 2 malocclusion, you can treat it either by extraction. Like in case of your class 2 malocclusion, you will go for upper 4 for extraction mostly. If a patient exhibits a class 2 molar relationship and a severe procrustation, then you will go for upper 4-4. And also you can treat this case with the distalization of the molars. And the distalization of molars, you can do it with the various appliances, like with the pendulum appliance, right? Like with the Jones jig, like with the distal jet, and your aqua appliance. So these are the appliances which are used or which are helpful in the distalization of your molar. So this is about the mild to moderate. When your class 2 skeletal pattern or your class 2 malocclusion is severe and skeletally it is due to the more prognathic maxilla, so in that case you will go for the surgery, that you will perform the maxillary setback. Why? Because there is a prognathism in the maxilla, you want to set back the maxilla. And in case of a retrognathic mandible, there is retrognathic mandible, so you have to take it out. It means you want to do the mandibular advancement, you advance the mandible. Now next is the management of class 3 malocclusion. So in this, the molar relation is in class 3. It means the mesiobuccal cusp, it lies between the interdental space of the mandibular first and the mandibular second molar. So in this, in a patient of class 3 malocclusion, the molars are in class 3 relationship, and in this the incisor, these may be in edge to edge bite. That is an edge to edge bite. The upper arch is narrow and the lower arch is broad. There is a posterior cross bite, which is the most common feature, important for your MCQ. So in the class 3 malocclusion, the posterior cross bite is most common, and in this patient having a concave profile. This profile, concave profile. Why? Due to the protrusion of the ortho, due to the prognathic mandible, the patient having a concave profile. So skeletally, the class 3 malocclusion, it may be due to the retrognathic maxilla, it may be due to the prognathic mandible, or it may be due to the combination, that is due to the retrognathic mandible, maxilla, and the prognathic mandible. Right. So after this, coming on to the class 3 malocclusion. So if a patient comes to you in a growing age or in a growing individual, the class 3 malocclusion may be skeletal or dental. You treat the skeletal class 3 malocclusion. If there is the maxillary retrognathism, you will treat it with the face mask therapy. Your main aim is to protract the retrognathic maxilla. So in that case, you will give the face mask. Next is, if a patient comes to you with a prognathic mandible, in that case you will go for the chin cup. Chin cup is used to redirect the growth of the mandible, or chin cup, it is used to restrict the growth. Right? And in case a patient comes to you with the combination of like maxillary retrognathism and mandibular prognathism, in that case you will go for your face mask for the maxillary retrognathism, your chin cup for the mandibular prognathism, and you will also go for the myofunctional appliances. Like in this case, you go for FR3, your function regulator 3 appliance. Fine. So this is in the skeletal individual. Fine. And in your chin cup, you will go for the occipital pull chin cup or the vertical pull chin cup. Fine. And if the cause is dental, you will go for the orthodontic treatment. This is all about in a growing individual. Now let's talk about the non-growing individual comes to you with a chief complaint of the class 3 malocclusion of a prognathic mandible or your retrognathic maxilla. So dentally, you will go for the orthodontic treatment, and skeletally, if the class 3 malocclusion is mild to moderate, you will go for the extraction. Fine. And if it is severe, it is either due to the retrognathic maxilla, so in that case you have to take the maxilla out. It means you have to advance the maxilla. So in that case you will go for the maxillary advancement surgery. And for the prognathic mandible, you need to retrude the mandible, you need to set back the mandible. In that case you will go for the mandibular setback. Now next we are going to discuss about the open bite. So basically we have two types of open bite. We have anterior open bite, we have posterior open bite, right? So in the anterior open bite, where there is no overlap between the incisors, so these are the incisors and these are the lower incisor, so there is no overlap. It means you will have a space in between your upper and your lower incisor. In between of them you have a space. So in this, according to the classification of open bite or your anterior open bite, we have the skeletal open bite, we have the dental open bite. So the skeletal open bite, it may be due to the excessive vertical growth, right, and which leads to the severe open bite. Important for your MCQ. The skeletal open bite, it is due to the excessive vertical growth and it may lead to severe open bite, and the skeletally it may lead to your increase lower facial height, increase in the anterior facial height, decrease in the posterior facial height. There is a steep mandibular plane angle, the long and the narrow face. In this the patient exhibit a long and a narrow face. There is a narrow maxillary arch and there will be a posterior cross bite. Very important point for your MCQ. So next is the dental open bite. So in this you can see the patient having a proclination in the upper anterior. There will be a spacing between the maxillary and the mandibular anterior teeth. These are your maxillary anterior teeth, these are your mandibular anterior teeth. So in this there will be spacing. It means there is no vertical overlap. And in this you will see that the patient having a narrow maxillary arch. Fine. So before going on to the treatment part, let's discuss some of the important points. See, the open bite, it may be due to the two causes. It may be due to the infra-occlusion of the anterior. You can give the box elastic. These are your upper canine, your incisors, your upper canine. These are your lower incisors and your lower canine. So you give, these are your brackets. So you give an elastic in a shape of a box. These are the box elastic, right? So after the box elastics, next is the MEAU. It means the multi-edgewise arch wires. These are this, fine. Next is the open bite. It may be due to your supra-occlusion of the posterior teeth, that your molars are occluded, or there is a supra eruption of the posterior teeth. In that case you will also get an open bite. In that case you will go for the high pull headgear, and with the implants you will correct the open bite. So next are the treatment of the open bite. So first you have to remove the cause. For example, in a patient having the habits of thumb sucking or the tongue thrusting, these are the primary cause of your anterior open bite. So in that case you have to remove the cause by giving the habit breaking appliance, by giving the tongue clips, by giving the rakes, etc. Fine. Next you will go for the myofunctional appliances like the Frankel 4 appliance or a modified activator. And in the fixed appliances you will give the box elastics, and you will also do the extraction of the upper all the premolars for the correction of the open bite. You will also go for the high pull headgear, the chin cup, and the surgical correction. So these are the treatment modality or the treatment of the anterior open bite. So after this, coming on to the posterior open bite. So in this there will be lack of contact between the posterior teeth, which we call as a posterior open bite. So the treatment of the posterior open bite is the lateral tongue spike. So next we are going to discuss about the deep bite. So it means the excessive overbite. The deep bite are of two types, the skeletal and the dental deep bite. First we are going to discuss about the skeletal deep bite. The skeletal deep bite, it may be due to the upward and the rotation of the mandible, and it further worsened by the downward and the forward rotation of the maxilla. Right, so in this you will see that there is an horizontal growth pattern. the anterior facial height of a patient decreases, the freeway space is also decreases. And in the cephalometric reading, you will see that there is the mandibular plane, the FH, that is the true plane, and the sella to nasion. All these three planes are parallel to each other. Very important for your MCQ. Fine. So this is about the skeletal deep bite. Now coming on to the dental deep bite. The dental deep bite, it may be due to the two reasons. It may be due to the pseudo deep bite. It may be due to the true deep bite. So the pseudo deep bite, it means that the dental deep bite, it is associated with the supra-erupted or the supra-eruption of the anterior teeth that are usually your lower incisor. Fine. And in this, due to the pseudo deep bite, you will see that a patient having an excessive curve of Spee. So the treatment in case of a pseudo deep bite is you can give the utility arch, which was given by Ricketts. You can give the 3-piece intrusion arch, which was given by the Burston. Fine. So in case of the pseudo deep bite, you will give your utility arch and the intrusion 3-piece intrusion arch. Right. And second is, if your deep bite or your dental deep bite, it is due to the infra eruption of the posterior teeth, that is due to the infra eruption of the molar, this is what we call as true deep bite, and it can be treated by giving the anterior bite plane, right, and by giving the low pull headgear, by giving the elastics, by giving the reverse curve of Spee arch wire, and by giving the activator. Very important commonly asked MCQs. And the pseudo deep bite, it is due to the supra eruption of anterior teeth, that are mostly the lower incisor, and the true deep bite, it is due to the infra eruption of the posterior teeth, that are due to the molars. So after this, next is the cross bite. So the cross bite, it means there is an abnormal occlusion in the transverse plane. Right? This is what we call as a cross bite. Fine. So it is of two types, anterior crossbite and posterior crossbite. Right? So the anterior crossbite, it may be defined as a malocclusion which results from the lingual position of the maxillary anterior teeth in relationship with the mandibular anterior teeth. In this, it means there is a lingual position of the maxillary anterior teeth in relation to the mandibular anterior teeth. Fine. So the crossbite, these are basically of three types. We have the skeletal crossbite, we have the dental crossbite, and the functional crossbite. The skeletal crossbite, it is associated with the retarded maxillary growth, or it may be due to the retrognathic maxilla and prognathic mandible. And in this, the patient having a narrow upper arch. Next is the dental crossbite. It is due to the lingual eruption of the maxillary anterior in relation to the mandibular anterior. It may be due to the tooth material and arch length discrepancy, important for your MCQ. And the functional is due to the occlusion interference as seen in the pseudo class 3. In this, due to the presence of any occlusion interference, the patient bring his mandible in a forward direction during the jaw closure. It is seen in the pseudo class 3. So next is the management of the anterior crossbite by using the removable appliances and by using the fixed appliances. So the removable appliances are the use of a tongue blade. So the tongue blade, it is mostly the ice cream stick, and it is placed inside the mouth. This area, it is contacting the palatal surfaces of the tooth which is in crossbite, and the blade, it is made rest onto the mandibular tooth in crossbite. Right? And it acts as a fulcrum. So in this, ask the patient to rotate the oral part of the blade in the upward and in the forward direction, and this is continued for 1 to 2 hours for about 2 weeks. Right? Second is the Catalan's appliance. So what is a Catalan appliance? So there is a inclined plane which is constructed on the lower, very important, it is constructed on the lower anterior teeth. For example, these are the incisal edges of the lower anterior teeth. So your Catalan appliance or your inclined plane, it is constructed on the lower anterior teeth to treat the crossbite. Fine, and it is made up of the acrylic, and it is used to treat the single tooth crossbite or a segmental or a segment of the upper arch crossbite. Very important point which is commonly asked, the angulation. It is 45 degree, commonly asked MCQ. So the angulation is of a Catalan appliance is 45 degree. And Z spring, it is also used to treat the anterior crossbite. Now coming on to the fixed appliances, so in this you need to place the bracket. It is also corrected by using the multi-looped arch wires, and also corrected by using the night-eye arch wires. Right? So the management of the posterior crossbite is, you can give the crossbite elastics, the quad helix to expand the arch, expansion screw, and the coffin spring. These are used for the posterior crossbite, again important. And lastly, the midline diastema. So what is midline diastema? It is the anterior midline spacing which is present between the maxillary incisor, between the two central incisors. And the causes, maybe it is due to the ugly duckling stage in the mixed dentition period, and it is the self-correcting anomaly which is corrected itself by the eruption of the your canine. So ugly duckling stage in the mixed dentition period, it is self-correcting anomaly, and if the gap it remains as it is, it will cause the, or it will said to be a midline diastema. And it may be due to the tooth material and arch length discrepancy, due to the presence of mesodents between the two central incisors, due to the abnormal frenal attachment, very important and most common, due to the thick and the fleshy frenum. So in that case you will go for frenectomy. But you will go for frenectomy, first you need to place the bracket, you need to close the space between the two central incisors. When you close the space between the two central incisors, then only you will go for the frenectomy. Fine. And to check for the abnormal frenal attachment, the test is the Blanche test. It is used to check for the abnormal frenal attachment. Next are the pressure habits. Any kind of pressure habits leads to the midline diastema. Fine. So the management is removal of the cause, like removal of the habit. Fine. And if it is due to the presence of mesodent, just extract the mesodent. You can give the removable appliances at the split labial bow, the finger spring. The finger spring is like this. It is used for the mesodistal movement of a tooth to close the space. It is particularly used in the midline diastema, and also the split labial bow. And in the fixed appliances, when you place the bracket, you will go for the elastics, that is mostly the elastomeric chain, that is the E chain is most commonly used to close the midline space. The springs, that is the M spring and the E chains. These all are your appliances which you are used to close the space of the midline, that is the midline space. Right? So guys, this is all about the management of the various malocclusions. Please go through it once and try to make the notes. Thank you.